Dear Chairman, dear colleagues, good morning. To begin with, I'd like to thank Professor Diamandi for inviting me to this meeting. This is the outline of the presentation. Insulin therapy is the only treatment for type 1 diabetes and the most effective treatment for type 2 diabetes when properly indicated. The primary goal of the treatment is to safely match the insulin needs of the patient. The major limitation is that current insulin regimens do not accurately reproduce physiologic insulin secretion. The efficacy of insulin therapy mainly relies on two parameters: the insulin levels in the blood, which are related to the pharmacokinetic aspect of the treatment, and insulin action in the tissues, which is related to the pharmacodynamic aspect of the treatment. Insulin absorption is a factor influencing insulin levels in the blood, and insulin sensitivity is a factor regulating insulin actions in the tissues. Exogenous insulin may be administered in many ways. Intravenous administration or intramuscular injection occurs sometimes, while the main mode of administration is subcutaneous injection. Inhalation or pulmonary administration is an emerging mode of administration, while nasal and oral administration, as well as intradermal administration, are experimental. So when talking about insulin absorption, mainly means when administering insulin subcutaneously. How is insulin absorption evaluated? In clinical studies, by measuring serum immunoreactive insulin levels in relation to time following subcutaneous injection of insulin preparation, and also by measuring the disappearance rate of radioactivity after subcutaneous administration of radio-labeled insulin preparation. In this figure, you can see the curves obtained by measuring serum insulin concentrations in patients with type 2 diabetes after administering various types of insulin and for a time period up to 24 hours. But these methods do not assess only insulin absorption, but insulin distribution, metabolism, and elimination as well, which are the four components of the pharmacokinetics of any medication administered in an organism. How is insulin action evaluated? In clinical studies, by using the euglycemic glucose clamp technique and calculating the glucose infusion rate. In this figure, you can see the curves obtained by calculating the glucose infusion rate and in type 2 diabetics, after administration of various types of insulin and for a time period of up to 24 hours. It's from the same review than the figure before. So, variability of insulin absorption is defined as changes in the absorption rate into the bloodstream of subcutaneously administered insulin, even when injected at the same dose under the comparable conditions, resulting in a lack of an identical metabolic effect. There is a between-subject variability or inter-individual variability, and also a within-subject variability or intra-individual variability, meaning that in the same patient, when the same dose of insulin is administered, we have differences in absorption at different time points. So variability of insulin absorption affects insulin action, leading to affecting efficacy of insulin therapy, and finally, affecting metabolic control of diabetes. The factors influencing absorption of insulin may be related to insulin preparation, like type of insulin, resuspension, dose, concentration, and volume, or factors related to the injection technique, like injection area, injection site, injection depth, and lipodystrophy, and also other factors like temperature, physical activity, massage, and sauna. The types of insulin that are currently in use are human insulins and insulin analogs, both produced by recombinant DNA technology. Human insulins are categorized based on the time action profile into short-acting, intermediate-acting, and biphasic premixed insulins, while insulin analogs are categorized into short-acting or rapid-acting, long-acting, and biphasic premixed insulin. Insulin analogs are a major progress in the insulin therapy because they mimic better physiological insulin secretion due to the pharmacokinetic properties. Insulin and insulin analogs must be in the form of monomers and dimers to be able to diffuse in the interstitial fluid and enter the blood vessels. The rhythm and extent of the formation of insulin hexamers at the injection site and the dissociation of insulin hexamers to monomers are important regulators of exogenous insulin absorption rate. Modification of these parameters aims to improve mimicking the dynamic endogenous insulin profile. Regular human insulin tends to form hexamers when injected subcutaneously, and there is a significant time lapse between hexamer formation and dissociation into dimers and monomers. So this results in a rather slow absorption time, leading to slow onset of action and delayed peak of action, and is related with the observed absorption variability. In contrast, rapid-acting insulin analogs have a reduced tendency to form hexamers, leading to a quicker absorption time. And quicker absorption time results in faster onset of action and shorter duration, and is related with the observed reduced absorption variability. Neutral protamine hagridon, or NPH insulin, is a crystalline suspension of insulin protamine complexes with zinc. These complexes dissolve slowly following subcutaneous injection, providing an intermediate-acting insulin. Aggregates of insulin protamine complexes at the injection depot vary in shape and size from one injection to another according to the depot environment and injection technique, so resulting to absorption variability. Glargine, soluble at acidic pH, when injected subcutaneously at the neutral pH of the tissue, precipitates and forms crystals, which then redissolve, and these procedures are inherently variable. But glargine presents less within subject absorption variability than NPH. Ditimir and diclutec are pH-neutral preparations, and when injected in subcutaneous tissue, remain in solution. Ditimir is an acylated insulin analog with a 14-carbon fatty acid, and this molecule presents self-association to dihexamers at the injection site and reversible binding to albumin, both in the injection site and in circulation. Diglutec is an acylated insulin analog with 16-carbon fatty acid in a dihexameric form. And this molecule presents soluble multi-hexamer chain formation at the injection site, and release of zinc from these multi-hexamer chains results in a highly predictable gradual dissociation into dimers and then monomers. So detomir and diglutec present lower within subject absorption variability compared to NPH insulin. Any crystalline suspension of protaminated insulin needs resuspension, and this applies for NPH human insulin, which has to be resuspended before each injection. The same is for biphasic premixed human insulin preparations, which contain NPH insulin. Appropriate resuspension is obtained when the insulin pen is inverted 10 times and then rolled between hands another 10 times. Inadequate resuspension contributes to insulin absorption variability. The same applies for biphasic premixed insulin analogs, which are a co-formulation of soluble listro or aspart, which is the rapid-acting component, and crystalline protaminated forms of insulin listro or aspart, which have the action profile of an intermediate-acting insulin. It has to be noted that neither insulin glargine nor insulin ditimir can be combined with rapid-acting insulin analogs, as this combination substantially alters their pharmacokinetic properties. In contrast, insulin diglutec can be combined with short-acting analogs, and a soluble co-formulation of insulin diglutec and insulin aspart is under development, where the pharmacokinetic and pharmacodynamic properties of each component are preserved. Now, up concentration of insulin preparation may affect insulin absorption. And this is the case for insulin glargine 300 units per ml, which is a more concentrated formulation, but with slower absorption. And this is attributed to the lower volume of injected insulin and of more compact precipitates compared to those of glargine 100 units per ml. And the mechanism is supposed to be that the surface area from which absorption can occur is reduced. Insulin glargine 300 units per ml presents decreased absorption variability versus other available basal insulins. However, because of these differences, insulin glargine 100 units per ml and 300 units per ml are neither bioequivalent nor directly interchangeable, which means that doses adjustment should be done when switching from one preparation to the other. Up concentration of insulin preparations may not have an impact on insulin absorption, as this is the case for insulin diglutec 200 units per ml, which is also a more concentrated formulation, but has similar pharmacokinetic and pharmacodynamic properties with diglutec 100 units per ml. So in this case, there is no need for changing doses when switching from one preparation to the other. And also, insulin Lispro, 200 units per ml, is a more concentrated formulation with no differences concerning pharmacokinetic and pharmacodynamics from Lispro 100 units per ml. So again, no need for changing doses when switching from one preparation to the other. There is no clear explanation why this is happening, but a hypothesis has been proposed that there might be a threshold of insulin concentration affecting absorption. Injection area may affect the absorption of insulin, and it is known that human insulin is more rapidly absorbed when injected in the abdomen, followed by the upper arm, the thigh area, and the gluteal region. This has practical implications because the abdomen may be the preferred site for regular insulin and for the morning dose of biphasic premixed and human insulins for a better control of postprandial glycemic excursions, since absorption is fastest there. And also the thigh or buttock may be the preferred site. The preferred site. And also the thigh or buttock may be the preferred site for the evening dose of NPH insulin and for biphasic premixed human insulins, when the risk of nocturnal hypoglycemia is a concern, since absorption is lower there. But it has to be noted that insulin analogs do not show variable absorption depending on insulin injection area. Rotation of injection sites is defined as the change of injection site in a systematic cyclic way. Injection sites can be rotated from one injection area to another, abdomen to thigh to buttock to arm. But same injection area has to be used at the same time each day. It's the same time, same place rule. Injection sites should always be rotated within the same area in order to reduce the risk of lipodystrophy and to ensure consistent insulin absorption. Correct rotation of injection sites involves spacing injections at least 1 centimeter apart within an injection area and avoidance of using the same injection spot in less than a week interval. These are proposed rotation schemes concerning the abdomen and the thighs, and another series of proposed rotation schemes concerning the abdominal area, the thighs, and the buttocks. So what is the clinical significance of rotating correctly injection sites? It has been shown that patients present less lipodystrophy reaction, lower HbA1c levels, less unexplained hypoglycemia, less glucose variability, and lower total daily dose of insulin. This is very nicely shown in the very recent injection technique questionnaire study published in 2016, where they showed that HbA1c levels is lower in patients who correct rotately, and the mean difference is 0.05 of HbA1c, and also there are lower total daily dose of insulins, and the mean average is of difference is 10 units per day. So, correct rotation of injection sites is related to lower insulin absorption variability. Lipodystrophy reactions to insulin injections comprise lipoatrophy and lipohypertrophy. Lipoatrophy is defined as the loss of subcutaneous fat in sites exposed to insulin, considered to be a local immune reaction against fat cells, and this is a rare event since the use of human insulins. Lipohypertrophy is defined as the accumulation of subcutaneous fat tissue or change in its texture at sites where insulin has been injected or infused repeatedly. Lipohypertrophy remains a frequent complication of insulin therapy, with a prevalence ranging from 14 to 50% in the literature, irrespective of the insulin type. Risk factors are incorrect rotation of injection sites, use of smaller injection zones, more years on insulin, and reuse of pen needles. Insulin absorption from such abnormal sites is erratic, thus leading to an increase of total daily dose of insulin, as nicely shown in Table 4 from the injection technique study, and also into higher HbA1c levels, as also nicely shown in the Table 5 of the same study. Insulin should be injected in the subcutaneous fat, and this can be achieved by the use of a 4 to 5 millimeter pen needle and injecting at a 90 degrees angle, or by pinching a fold of skin to pull the skin and fat away from the underlying muscle and inserting the needle into the skin fold. In this picture, insulin injection without raising a skin fold, and in that picture, insulin injection by raising a skin fold. However, intramuscular injections may occur, and this happens more frequently when patients use longer needles equal or greater than 6 millimeters, in slimmer and younger patients, in males, and in patients who use the upper arm or the thigh area rather than truncal sites for insulin injection. Intramuscular injection of insulin results in faster absorption of insulin, leading to excessive glycemic variability and unexplained and frequent hypoglycemia. High temperature of the injection site accelerates insulin absorption, so patients are instructed to avoid injecting insulin immediately before or after taking a hot bath or being in a sauna. Physical activity can also increase the rate of insulin absorption, so patients are instructed that if physical activity is planned, they should avoid injecting insulin in the muscle group most used in that activity. For example, if a patient is going to do brisk walking, he should not inject insulin in the thigh before taking the exercise. And does insulin absorption variability differ in the elderly patients? There are no difference of pharmacokinetics of insulin preparations between geriatric and younger patients. But poor injection technique may be more prevalent in elderly patients. They have more often impairments in dexterity, cognition, vision, and hearing. And also age-related changes in the skin, like epidermal thinning, dermal atrophy, and reduced subcutaneous fat, presents difficulty in lifting, leads to difficulty in lifting a skin fold for insulin injection, and so the use of a 4 to 5 millimeter pen needle and injecting a 90-degree angle is preferred. And also physical activity is more often reduced, being a less important factor affecting insulin absorption. Concerning the clinical relevance of insulin absorption variability, variable responses to the same insulin dose within the same patient result in glucose variability and increase the risk of unexpected hypoglycemia, nocturnal hypoglycemia, and hyperglycemia, thus leading to suboptimal glucose control. Other clinical aspects are increased weight gain associated with defensive eating to prevent hypoglycemia, increased anxiety associated with frequent hypoglycemic episodes, reduced patient confidence in the treatment due to inability of achieving disease control, increased risk of development and/or progression of diabetic complications, and finally increased risk of mortality. What the clinician should do: design an insulin delivery profile to give the best possible glucose control to the patient, aiming from the closest to physiology insulin profile and aiming to minimize the variability of insulin absorption. It has to be mentioned that the more consistent is the absorption of an insulin preparation, the more predictable is the glucose-lowering effect of this preparation. So to avoid insulin dosing errors, it should be noted that for insulin titration, it is important that the same insulin dose results in as a similar glucose-lowering effect as possible following each administration. Consequently, an insulin with a more predictable glucose-lowering effect should provide greater confidence in safely adjusting doses and thereby be more effective in achieving recommended glycemic targets. Also, perform a check of injection sites by physical examination at least once a year on all patients injecting insulin. For those found to have lipohypertrophic lesions, physical examination should be performed even more frequently. And in some cases, ultrasound may be used. Checking sites routinely has been shown to be associated with lower HbA1c levels, less lipohypertrophy, lower total daily dose of insulin, and more correct rotation of injection sites. To check patients' injection technique and improve patients' education will also help to avoid insulin dosing errors. So in conclusion, insulin absorption variability leading to variable and unpredictable peaks in insulin action can result in unexpected hypoglycemia and hyperglycemia. Clinicians dealing with patients with poor metabolic control should consider the issue of insulin absorption variability and try to minimize it. In addition, further improvement in reducing the pharmacological variability of rapid and long-acting insulin preparations are expected to lower the risk of overall and nocturnal hypoglycemia and hyperglycemia, as well as simplify optimal insulin titration in clinical practice. Now we will proceed to the presentation of cases. Yes. Yes. It's very quick. It will be very quick. So the first case is a 72-year-old woman with a history of diabetes mellitus since the age of 54, treated with insulin since the age of 69, who presented in the outpatient clinic, and she was obese. She had a history of hypertension and hyperlipidemia, and she was mildly active. Her renal function was normal. Her current insulin treatment were 2 daily injections of biphasic pre-mixed insulin analog aspart and protaminated aspart. Her recent HbA1c value was 8.7. The fasting pre-meal and bedtime blood glucose levels were between 70 and 280 milligrams per dl, with most values exceeding 200 milligrams per dl. She reported hypoglycemia occurring 1 to 2 times weekly between meals and at night in the absence of a definable precipitating event such as a change in dose, diet, or activity, and she was concerned about hypoglycemia. By reviewing her injection technique, it was realized that she did inadequate resuspension and sometimes even skipping resuspension of insulin. So the importance of adequate resuspension was stressed, and she returned to the clinic 3 months later. She had reduced the total daily dose of insulin by 6 units, her blood glucose profile was improved, her last HbA1c value was 8.1, and she reported less hypoglycemic episodes. So to relate inadequate resuspension and glucose variability, inadequate resuspension leads to reduced insulin absorption, which then results in reduced insulin bioavailability, causing hyperglycemia, and this leads to increase of insulin doses. Occasions when patient injects insulin after adequate resuspension, then normal insulin absorption ensues, and there is expected insulin bioavailability, but hypoglycemia results as doses are exceeding insulin needs. And the second case is a 75-year-old man with a history of diabetes mellitus since the age of 62, treated with insulin since the age of 68, who presented in the outpatient clinic, and he was also obese. He had a history of hypertension, hyperlipidemia, and coronary heart disease. His renal function was slightly impaired, and he was sedentary. His current insulin treatment was a multiple injection regimen with 46 units of insulin glargine and 10 to 14 units of glulicine with each meal. His recent HbA1c value was 9.4, and the fasting pre-meal and bedtime blood glucose levels were between 70 and 330 milligram per dl, with most values exceeding the 200 milligram per dl. He reported unexplained hypoglycemia after meals occurring 2 to 4 times weekly, and some episodes were severe. Nocturnal hypoglycemia was rare. He was not so keen in rotating sites, and most injections were in the abdomen and some in the thighs. Checking in the injection sites by visual examination and palpation revealed lipohypertrophic lesions in the abdomen. He admitted injecting occasionally into these lesions, and when asked why, he answered that he thought this was not so important and that injections were often less painful there. So rotation technique was revised. Avoidance of injecting into lipohypertrophic areas was stressed. And 3 months later, he had reduced the total daily dose of insulin by 10 units. His blood glucose profile was improved. His last HbA1c value was 8.5, and he reported less hypoglycemic episodes. And so to summarize the events relating lipohypertrophy with glucose variability, insulin absorption, when injected in abnormal sites, may be either reduced or delayed. Reduced insulin absorption is leading to reduced insulin bioavailability, thus leading to hyperglycemia and an increase of insulin doses. When insulin absorption is delayed, then peak insulin action mismatches post-meal glucose excursions, thus leading to hypoglycemia. When the patient switches from abnormal to normal injection sites, there is normal insulin absorption, there is expected insulin bioavailability, and this leads to hypoglycemia because doses are exceeding insulin needs. Thank you for your attention.